This is the Central Nervous System, Chapter 12B, or Part 2. When we are looking at the brain, we've already commented on the four main parts of the brain. So this is continuing on looking at some of the functional brain systems. So you have a network of neurons. They're all working together, but they're not located in just one area. Like they're not just located within the cerebrum or just in the cerebellum. They're spanned out throughout the brain. And this includes the limbic system and the reticular formation. We're looking at the limbic system first. This includes nerve fibers, basically. They're going through the cerebral hemispheres and the diencephalon. So they do track and link the limbic system and the fornix area. The limbic system is going to play a large role in your emotional aspect of the brain. The amygdaloid body is going to recognize, so you have certain areas that recognize very changing expressions on the face, like angry, and it can recognize, okay, that's an angry facial expression, that's a fearful facial expression, and that's recognizing these different emotional connotations, if you will. It will play a role with helping to elicit the fear response, assessing, are you in danger or not? You have others that play a role in expressing emotions by gestures. Are you using a lot of hand gestures? And helping to resolve mental conflict. And so this is showing the areas highlighted that are part of the limbic system. So you can see they are spread out throughout the brain. Now, just on a side note, with being able to recognize facial expressions, that is something that has come out recently. Something that I find kind of interesting is concerns over people who are doing so much work online, younger generations who are used to texting everything instead of talking with people in person. Will younger generations who are so used to everything being online, everything on their smartphone, may not be as familiar, and just because they don't have as much experience in interpreting a lot of the nonverbal language. Looking at the facial expressions, can you tell that this person's getting upset? Or is this person scared? Are they getting angry? Or are they fine? Are you picking up on those nonverbal cues and are able to interpret them correctly or not? And that's been a concern. Another thing that I read recently is that during the pandemic, with people wearing masks, are you able to fully interpret, once again, the facial expressions? So it'll be interesting to see long term what happens with that. The limbic system also puts emotional connotations on odors. Like I say, good, bad, or indifferent. Part of that is because the nerves pass through the system. The olfactory nerves pass through it. And so, okay, like it's saying here, skunks smell bad. And it plays a role with your emotions, your memories, etc. Another example that I can give you is personally, my mother was a wonderful cook. Excellent. There was one dish, however, that she used to make periodically, and my sisters and I would rotate around who had to wash the dishes after the meals. And if you knew she was making this dish for dinner, you would really try to kind of, we'll just say, I remember purposely, say, offering to do the dishes for lunch so that I knew I wouldn't be stuck with that dish for dinner, because like I said, she was a wonderful cook, but she used to periodically make Boston baked beans. And I don't know why, but every time she made them, she would burn the daylights out of them. And that pan was horrible to have to try to clean. So you didn't want to be the one washing. To this day, if you say Boston baked beans to me, I immediately can smell that burnt bean smell, and there's just sort of a dread actually with me of like, oh, that's going to be so awful to have to clean that pan. The house is going to smell. Several years ago, I actually went to a conference in Boston, and several of the restaurants were advertising their either the Boston clam chowder or Boston baked beans, and I was like, I can't. I just couldn't try it. I just couldn't do it because I just have this not so pleasant connotation with that food item, and a lot of it has to do with the smell. If you guys have ever burnt food really bad, you know what I'm talking about. It's just like, oh my goodness, cannot do it. But that all has to do with the limbic system, how it ties in this case, the smell, the taste with the emotion and memories. It all is tied in together. The limbic system is also involving the hypothalamus. The hypothalamus plays a role with psychosomatic illnesses as well. As I say, it's going to interact with different areas, including the prefrontal lobes. So like I say, it understands or allows us to react emotionally to things we understand they're happening. Like I say, some of it bad, some of it good. And those memories are going to be there. The reticular formation extends through the central part of the brainstem. There's 3 different areas, as you can see here. It allows connections to govern basically arousal of the brain. So the reticular activating system, or RAS, will send impulses to the cerebral cortex, kind of to keep it alert. Hey, you know, don't go to sleep. Stay alert, stay conscious. Now, it tends to filter out a lot of repetitive stimuli because you don't need to be consciously aware of every stimulus coming in. We would all be totally overwhelmed and crazy. You don't have to be aware of the temperature in a room when you're sitting there studying. You might be aware when you first walk in, but then you get used to it. The RAS system is inhibited by sleep centers, alcohol, drugs. Severe injury can result in the person becoming unconscious and slipping into a coma. The motor functions of it help to control very kind of gross, large movements of your limbs. There are different autonomic centers that are regulating more of your visceral motor. Remember, visceral is referring to your internal organs, such as the heart, the lungs, your abdominal, pelvic organs. So this is just showing the interconnections between them. Now this table, which is kind of large, goes through. It's a very good table because it puts everything in one spot. It's a nice summary of the different areas of the brain and what their function are. So it goes through the cerebral hemispheres, the diencephalon. You've got the limbic system listed there. You've got the brainstem and the reticular formation there, and then the cerebellum. So it's nice to have it all in one place and to have that summary. As we move on, looking at higher mental functions, analysis of some of these functions, such as language, memory, we're going to look at brain waves, consciousness, and the sleep-wake cycle. So when we look at language, most of the language system is going to, in terms of interpretation, is on the left hemisphere. There's 2 main regions. I have spoken about this in part 1, but review it again here. The Broca's area, this is involved with producing speech. If there is damage or lesions or tumors here, you can understand when someone is speaking to you, but you cannot respond back. You may know what you want to say, but you cannot put basically your thoughts into words. The Wernicke area is involved with understanding the spoken words and the written words. So, someone that has damage to the Wernicke's area, they can speak, but if there's damage there, it's not going to make any sense. It's just going to be garbled nonsense. And that is showing, let me get my pointer on, this is the Broca's area here, and then this is the Wernicke area back here. For memory, there's different kinds of memories. There's what we call declarative memory, which is memory of facts, so dates, names, faces. There's procedural memory, which is memory of different skills, playing the piano, things like that. Motor memory is memory of motor skills, like being able to ride a bike. Emotional memory is memory of experiences that have some type of a link to an emotion. You have a memory of, if you heard a rattlesnake, probably your heart's going to start. There's two stages of declarative memory. There's short-term memory and long-term memory. Short-term memory is going to be limited to how many pieces you can just quickly learn. What are some factors that will affect whether short-term memory goes to the long-term memory, which is indefinite storage? Your emotional state. You have a higher chance of it going from short-term to long-term if you're very alert, if you're very motivated, if you're surprised, if you're aroused. So if you're kind of drowsy and sleepy, you may not remember someone telling you, hey, you have to cook supper tonight. Rehearsal, that repetition, is with so many things. Repetition is so, so important. And then association, if you tie something new with something old, that's going to play a role. And then automatic, your subconscious information is often stored into the long-term memory. So all of these different outside stimuli will play a role. Vision, touch, hearing, smell, all of this information is coming in. Goes to short-term memory. Some of it, depending on what it is, may be lost. But some of it's going to be switched to long-term memory. Now you can retrieve, different things may allow you to retrieve that long-term memory items. They may be in the subconscious, but there maybe it's a site that triggers that. I remember years ago hearing a song, and I was laughing with my sister, and we had the music, we were playing it on the piano and stuff, and I kept saying, for some reason, I'm associating this with rain. This song, for whatever reason, is associated with rain. And finally, we were looking at something a couple months later, and all of a sudden it triggered because we saw something. There was a slideshow from way back that we were looking at, some old memories, and there was a picture of raindrops hitting on a pond. Well, the thing that we were looking at, it just so happened that the song that was playing in the background with that picture was the same song that we were playing earlier on the piano. And so it's somehow, when we were playing the music on the piano, in my subconscious, I was remembering that sound, but was associating with the picture from the slideshow of the raindrops hitting on the pond, which is why I associated then that song with rain. We look at brainwave patterns in EEGs. You're measuring the electrical activity that is there in the brainwave. Now, normal brain functions, obviously the brain never shuts off even when you're sleeping, so it's very hard to measure these functions. So what you can often do is look at the brainwave patterns. Run an EEG, an electroencephalogram, that records the electrical activity that corresponds to the brain function. You can use this record of this electrical activity, or the EEG, for diagnosing epilepsy and sleep disorders. You can use it in research. There, even at sleep, there is a pattern, electrical pattern with the brain. We know kind of what normal should look like, so that's why you can use it to help diagnose abnormal functions with it. If there is absolutely no electrical activity, that's what they're often talking about when they say there's no brain activity and therefore a person is brain dead. And that is often used to determine death. Now that has been a controversy over the years as to when do you determine death? Is it brain death? Is it heart? And it's an issue that has come up. So how do you do an EEG? Well, you're going to place electrodes on the scalp. It can pick up the electrical activity because you have fluid, so much of your body is water, and in the water you have dissolved sodium, you have chlorine, you have calcium, potassium. Those ions will are able to pass the electrical current to the surface. So you don't have to do anything invasive. You just put the electrodes on the scalp to measure the activity. So this shows an individual, excuse me, that has the electrodes set up. If it is a young child or an infant, they actually have the electrodes on a cap and then they put the cap on the child because it's hard to put the electrodes directly on a young infant. So the EEG is going to measure the electrical activity. Now each person's waves are unique, but there's certain patterns that you're looking for that we know that would be normal, etc. Those patterns change as you age. Their patterns will change when you have different stimuli. And so you're looking for changes. You kind of know what a general normal pattern is, and then you're looking for changes with that. There's 4 main groups: alpha, beta, theta, and delta waves. So the alpha waves, these tend to be very regular, very rhythmic type waves, and it indicates a nice relaxed, kind of, as they call it, idling brain. Beta waves are very rhythmic. They're a little bit less regular. It's when you're mentally alert. So hopefully right now you have beta waves. Theta waves are a little bit more irregular. These are more common in children. In an adult who is awake, you would not expect to see the theta waves. And then the delta waves are when you're in a deep sleep. Someone who's under anesthesia for surgery typically would have delta waves. If a person is awake, this would indicate an abnormality. So this is what they look like. So this is when you're awake, but you're relaxed. You're watching a game. You're forgetting about A&P. Beta waves, this is when you're awake and you're alert. So hopefully right now, this is kind of much more frequent. Theta waves, this would be common in children. Like I said, this typically is not seen in adults. And then the delta waves, when you're sleeping in a deep sleep, this is what it should be like. Years ago, all 3 of my kids had febrile seizures, and my son had 2 of them, so they wanted to do an EEG on him, which was interesting when you have a young infant, a young child under the age of 2, or he was about 2 at the time, and trying to, like I say, they have the cap with the electrodes because they couldn't put the electrodes directly on him. He was not going to have that. And actually what they did, at least in his case, they wanted him tired because they wanted him to be sleepy, and it was, if any of you have ever done this, it's not a pleasant experience for mom, because basically you have to keep the child awake until, in my case, I had to keep him awake all night and then bring him in, and because then they wanted him to fall asleep, be easier for them to They put the cap on, and so and because he was so young, they had a room with a reclining chair, I remember, and they had, because he was young, they had me sit in the reclining chair and hold him. And then they turned the lights down. They said, okay, hopefully he'll go to sleep. We'll run this. And they were, I don't even remember how long the process took, 45 minutes, an hour or something. I don't remember. I just remember laughing with the tech and saying, okay, you know, I've had to keep him awake all night, which means Mama's been awake all night, and you're going to turn off the lights. He's now asleep, which was good, but you've got me in a reclining chair holding him. You're turning the lights off. Do I have to stay awake during this procedure? Because I'm going to be out cold in a bit. That was also interesting from the standpoint that she's right there getting the readings. A little disconcerting when you hear the tech go, oh, oh. I'm like, are those good O's or bad O's? Well, she'd been doing this for so long, she kind of recognized with a child, she is expecting initially as he's awake more the theta waves, and then as he goes to sleep, hopefully into the delta waves. Now, because she's a technician, she really couldn't tell me too much, but later with the doctor, well, and she did tell me that his brain waves were more indicative of a younger, of an older person. And she's like, is he a little more advanced in things? Because his brainwaves are indicative of an older person, not a 2-year-old. And he actually was in the gifted program, so that kind of made sense. In terms of some clinical applications of EEGs, etc., they will use an EEG oftentimes to diagnose for epilepsy. What happens in an epileptic seizure, and there's different types of seizures, is that you suddenly have this increased discharge of the neurons are just firing. They just rapid firing, uncontrolled. And it prevents other messages from getting through. Now, like I say, there's different types of epilepsy. There's different types of the seizures that you may see. The person often will lose consciousness. They may get very stiff. They may have uncontrollable jerking with them. It doesn't cause brain damage, which used to be an old wives' tale thing they thought. Is there a genetic factor? For some there is. Oftentimes, so it's attributed to some type of a brain injury or an infection. There may be a tumor that may have caused it. Oftentimes what happens with people who have epilepsy, they may say that over time that they're able to pick up what they call an aura. There's kind of this, they often refer to it as a sensory hallucination that may precede the seizure. I've known people who've had epilepsy. My ex-husband had a form of epilepsy, and he got to where he could just sort of detect this odd feeling and kind of a, not lightheadedness, but his vision kind of changed a bit where he knew I better, at that time, he's only had a few of them, but he knew that if he were standing, he needed to sit down. If he were driving, he better pull over. And actually, once he's had a seizure, he could not drive for months. It depends on the state. I'll just say right now, it depends on this. Every state's a little bit different as to what their laws are. When he had his first seizure, we were in the state of New Mexico, and at that time, if you'd had a seizure, you could not drive for a year. Later, they reduced it to 6 months. I don't know what it currently is. So if you or you know someone who's had seizures and you're wondering what the effect is for driving, you need to check with your particular state because it varies state by state. Absent seizures used to be known as petit mal seizures. They're very mild in children. It's kind of where the expression goes blank for a few seconds. Tonic closure seizures, which were formerly known as grand mal seizures, are very severe. The most severe ones, they can last a few minutes. The victim loses consciousness. They can have very intense convulsions, loss of bladder control. They could bite their tongue. They're not going to swallow their tongue. That is impossible to do that. When someone is having a seizure, you want to make sure that they are not going to hurt themselves, so remove things from around them so they hopefully, don't break any bones. Uh, you don't want to stick your finger in the mouth because they may be clamping their jaw down. You can't stop it, so the main thing is the seizure is going to run its course, but you make sure that they don't hurt themselves. Because oftentimes they lose consciousness, they will not have a memory of the seizure. And like I say, some people, depending on the severity of the seizure, some people may completely lose consciousness, others may not. In my husband's case, one of the clues I had, oh, here we go, he started making kind of a clicking noise with his jaw and would just start just repetitive like that. And it's like, oh, here we go. He would not lose consciousness, but he would get a blank stare, similar to what you would see with the absence seizure. And he would have absolutely no memory of it afterwards. In fact, the first few times he had it, it took a while. He initially did not believe me that this had happened, didn't know why I was creating a fuss. But it wasn't until other people had to confirm that, yes, this is what you were doing. There are a lot of drugs that can help control epilepsy. They try to basically, in some ways, kind of calm and stabilize that activity of the brain. Consciousness involves this perception or sensation, and there's control over movements. There are different things associated with the higher mental processing, memory, logic, judgment. So we have different levels of consciousness, alertness, obviously, where you're very much aware of movement, sensation, and memories and judgment, etc. Drowsiness, stupor, and then coma. If you have loss of consciousness other than sleeping, that's obviously something you need to look into because it's a signal that something is happening in the brain that shouldn't be happening. Fainting is a brief loss of consciousness. Usually it's due to an inadequate blood flow to the cerebrum. It can be due to low blood pressure. Sometimes people's sudden standing that changes the blood pressure. Could be hemorrhage, could be a sudden, sometimes people will faint due to a very sudden and severe emotional stress. They've gotten some horrible information very unexpectedly. Be prepared to catch them as they fall. Coma is obviously unconsciousness for an extended period of time. It's not a deep sleep. The oxygen consumption is lowered. The only thing I would say is that when someone is unconscious, some people say, okay, oh, it's like they're sleeping, they're not going to hear anything. Person can be unconscious, and there have been reported cases of this, is that your sense of hearing is very, very sensitive. In other words, you may think the person is unconscious, but they may still be able to hear you. They may not be responding, but they may be able to hear you. And so certainly, for those of you who are entering into the medical field, be careful of what you say when you are working with an unconscious patient, because they may come back later and say, I remember hearing you say XYZ. So just be aware of that. Brain death is obviously irreversible coma, And like I said earlier, there's legal issues, ethical issues. What might initially sound something that should be very clear cut as to whether a person is dead or alive. When does death occur? And that's sometimes can be a complex issue. In terms of your sleep and then sleep-wake cycles, so when you're sleeping, you're partially unconscious. However, obviously a person can be aroused from that. You know, shake their shoulder and they'll wake up. Maybe step back so you're out of arm's reach from a hit. But when a person is sleeping, your cortical activity is depressed. Obviously, it's not stop. It's just depressed. Brainstem activity does not change. Remember, that's controlling your respiration rate, your blood rates. When you are sleeping, there's two major divisions of sleep, and we can measure this by the EEG patterns. There's the non-rapid eye movement or non-REM movement that's broken into 4 different stages, and then you have the rapid or REM sleep. You're going to pass through the first 2 stages of non-REM during the first 30 to 45 minutes of sleep. And then you're going to move into stages 3 and 4, which are referred to as slow wave. You can measure the waves and the frequency of them. So the frequency may decline, but then the amplitude, how high those waves are, is going to increase. The EEG, the heart rate, respiratory rate, blood pressure, all that's going to change. At about 30 minutes into sleep, that 4th stage ends and the REM sleep will just suddenly start. During REM or rapid eye movement sleep, temporarily there are certain chemicals that are released that basically allow for temporary paralysis, except for the eye movements. This is when most of your dreaming occurs, which is why there's temporary paralysis, so that obviously if you're dreaming that you're in a fight, you're actually not swinging your arms and kicking your feet. Oxygen consumption, heart rate, and breathing increases. And so, like I say, you can measure this. You know, if someone goes to like a sleep lab, they can measure this on the EEG. So here's when your person's awake. This would be the rapid eye movement. So you initially, relax. You're going to sleep. In this first initial stage, you can be very easily woken back up. Now you enter into stage 2. So all of these are non-REM. Get this pointer on, sorry. All of these blue background colored ones are non-REM sleep. The red up here is your normal awake. So stage 1 here, you're starting to go to sleep, so that's when you can be easily woken up. Stage 2, you're starting to get into a little bit deeper sleep. It's going to be a little bit harder to wake you up here. Stage 3, and then stage 4. In this stage, it's going to be harder to wake you up. If somebody sleepwalks, it's often during this stage right here. And then you're going to go into REM sleep. This is where most of your dreaming occurs. So you'll notice you go to sleep, you're awake, and see how it cycles through the night. So after stage 4, you move back up, you go into REM sleep, and then you're going to start over again. So it cycles throughout the night. There are different types of sleep disorders. Narcolepsy is where you're awake and you just suddenly fall asleep. They don't know exactly what's happening. They think that there are certain chemicals that are being destroyed by possibly the immune system. But I've known people, I knew someone that had a child that had this, and I can remember babysitting her one time, and we were talking. She loved the story Bambi, and she was talking about, yeah, and then Bam, And she just stopped literally in the middle of the word and just fell asleep. And of course, I mean, I'm babysitting, and I was like, oh my gosh, what's wrong with her? Um, and they were like, oh yeah, I told them, I said, man, she just, it's like you flip a switch. And like, oh yeah, we kind of forgot to tell you that she has this. It's like, that would have been nice to know ahead of time. Insomnia is kind of the opposite, where, and this is where you're having problems sleeping. You're having problems getting that good night's sleep. Now, we're not talking just one night. I mean, everybody's had a night where, I don't know, maybe you have a big presentation. Maybe it's the night before you have to take one of my exams. I don't know. Hopefully you don't stress out that much. But, you know, there may be something that you're stressed, you're worried about, that's keeping you awake. You're having problems falling asleep. We're not talking about a one-time thing. Insomnia is chronic. It means, you know, it happens over a long term. How do you protect the brain? Well, there's different things that help to protect it. The meninges. The meninges are a layer of membranes that cover both the brain and the spinal cord. They are there to cover and protect it. They're protecting the blood vessels that are coming in to supply the brain and the spinal cord. They do contain the cerebrospinal fluid. They are composed of 3 different layers: the Dura Mater, Arachnoid Mater, and the Polio Mater. Now, if we look at the skull, up here you can see the different layers. You've got the skin, you've got the periosteum, and then here's the bone of the skulls. So the outermost layer is going to be the Dura Mater. Now, the Dura Mater in the brain is subdivided into 2 layers, and over the spinal cord it's only 1. So these 2 layers right here are the Dura Mater. Then you have a subdural space. Then you enter into the arachnoid mater. And then you have the subarachnoid space. And then you have the pia mater. Now look that you've got the blood vessels that are running in the subarachnoid space right in here. And then the pia mater is that layer it's directly attached to the brain itself. So the Dura Mater is the strongest. Like I said, in the brain it's found in 2 sublayers, if you will. They're pretty much fused together. There are areas where you have what we call the duravenous sinuses. The sinuses are areas where it's collecting the return blood from the brain, and that's going to empty into the jugular vein in the neck, return that fluid back to the blood supply. The arachnoid mater is the middle layer. It kind of has these spider web extensions, which is how it gets its name. Beneath it is the subdural space. Now, in that the subdural space separates it from the Dura Mater, and then the subarachnoid space separates it from the pia mater. In the subarachnoid space is where the cerebrospinal fluid is. And as I showed you in that previous picture, that's where the blood vessels are going towards the brain, the main ones. There are different what we call arachnoid granulations, these little extensions that will extend from the arachnoid up through the Dura Mater into the sinus, those dura sinuses I just mentioned. That's going to help with reabsorbing the cerebrospinal fluid and getting it back into the venous blood supply. So we'll talk about how that works. The pia mater, so that's the innermost one, is directly attached to the brain. It's a very delicate type. All the maters are connective tissue. So in terms of clinical applications, meningitis, any word that ends in itis is inflammation. So meningitis is the inflammation of these meninge layers. Very serious if they're covering the brain and the spinal cord. We're talking about a very serious problem here. If it spreads and leads to inflammation of the brain itself, that is encephalitis then. So meningitis is inflammation on the meninges, either on the spinal cord or the brain. Inflammation in the brain is encephalitis. How do you diagnose meningitis? You usually have to get a sample of the cerebrospinal fluid. It is supposed to be sterile. If there are microorganisms in there, you've got a problem. How do they get the cerebrospinal fluid? They're going to do a lumbar spinal tap. That's done down in the lumbar area, as we'll see in a moment, where you cannot hit the spinal cord. But you can obtain the cerebrospinal fluid, get a sample of it, and test it. Just FYI, as a microbiologist, I can tell you meningitis, there is both bacterial and viral meningitis. Bacterial meningitis, because it is a bacteria, can be treated with antibiotics. Antibiotics do not work with viruses. So that's another whole ball game to have to try to treat it. Very serious infections, well, regardless of what the cause is. It's whether it's bacterial or viral, very serious infections. You need to start treatment immediately, and part of that problem is you need to diagnose it immediately so you can start treatment immediately. The cerebrospinal fluid, it acts as like a cushion, a shock absorber for both the brain and the spinal cord. It provides protection when there's a blow because it absorbs some of that force. It does help to nurse the brain. It carries different chemical signals with it. Think of if you had an egg and you put it in a jar and you shake that jar, well, it's going to bust. If you put an egg in a jar, but the jar has water in it, you'll notice it helps to protect that water. You shake that jar, you still may have some damage, but not to the extreme that you would without it. The cerebrospinal fluid is mostly water. It's formed from blood plasma. Plasma is the liquid portion in the blood, but it has less protein, it has a different ion concentration than what the blood would have. So the choroid plexus, these are found, a plexus is where you have like a small network of something, either a network of nerves, a network of blood vessels. In this case, the choroid plexus is where you have a cluster, a little network of capillaries. They tend to hang from the roof of each of those ventricles. Remember earlier we said you've got the two lateral ventricles, the third ventricle, and the fourth ventricle. So they're located in the roofs of each of those ventricles. They are surrounded by the epidermal cells. Remember, those were one of the types of supporting cells with the central nervous system. Their job is to produce the central or the cerebrospinal fluid, and it's going to be filtered from those plexus at a constant rate. So the epidermal cells have cilia. It helps keep the cerebrospinal, it's being released. It's kind of like keep moving along, keep moving along. How much cerebrospinal fluid are you making? Well, about 150 mils is replaced every 8 hours on average, they've been able to determine. So this picture is really kind of neat. Okay, once again, I'm a nerd, but okay. So this is showing up here with the lateral ventricle that you've got the choroid plexus producing that cerebrospinal fluid. It's going to flow from the lateral ventricle through the interventricular foramen into the third ventricle in this area right here. Third ventricle, it can now flow through the central aqueduct into the fourth ventricle. From the fourth ventricle now, the cerebrospinal fluid is going to flow into the subarachnoid space. How is it going to get there? It is going to flow through these apertures and start flowing around in the subarachnoid space. And then, I'm sorry, I have a cat that has just decided to jump on my keyboard. No. No, just sit. I'm sorry, I apologize for that. So the cerebrospinal fluid is flowing around through the lighter blue area is the subarachnoid space. Now remember where I said you've got these arachnoid granulations where it extends out? It's kind of like this pushing out into the Dura Mater space, into those sinuses. And that's what's going to happen here. The cerebral spinal fluid flows up in there, and it's filtered, basically, and is allowed to flow into the sinus area. From the sinus area, it's going to actually eventually flow towards the jugular vein. You can't see very well here, but it's going to flow into the jugular vein. Now, some of the, and then that way it gets that fluid back into the blood supply. Now, down here at the fourth ventricle, as some of it goes this way into the subarachnoid space, some of the cerebral spinal fluid also goes down the central canal, and some of it goes in the subarachnoid space around the spinal cord. So that way both the brain and the spinal cord are having the cerebral spinal fluid basically flush around it. It's lubricating, and it's providing some nutrients in there because it's coming from the blood. It has some nutrients in it. It's keeping it buoyant. It's protecting it. And like I said, this constantly excuse me, is being produced, filtered, and then reabsorbed into the blood supply, and then back around again. And this is showing at the choroid plexus. These are those epidermal cells that have the cilia on it. You're producing that cerebral spinal fluid. Here's a blood vessel forming that cerebral spinal fluid here. So if somebody were to ask you, like, where's cerebral spinal fluid made? It's made by the choroid plexus. How specifically? By the epidermal cells filtering out the blood plasma. What are some clinical applications or aspects of cerebrospinal fluid? Well, if you have any type of a blockage, something that's obstructing the flow of the cerebrospinal fluid so it cannot complete that whole process of flowing and then draining back into the blood supply, you're going to, it's blocked. It's going to start accumulating, and that's increased pressure. In a newborn, because the skull bones are not fused together yet, what's going to happen? Well, you're increasing that pressure. It's going to cause the head to enlarge. In adults, it's going to cause pressure on the brain. While the skull, the bones have fused together, so it's very rigid. The skull bones can't expand. The head cannot enlarge to deal with it. So what would happen is that increased pressure starts pushing against the brain, and it can cause brain damage. So how do you treat this? If you've got this increased pressure, you have to relieve the pressure. So you've got to drain that cerebrospinal fluid. How are you going to drain it? You put in a shunt. Basically, you put in a shunt so that instead of draining the way it's supposed to, because it can't because it's blocked, you drain it and you put a tube in and it drains to the abdominal cavity. Hydroencephalitis, water on the brain. That's what this is. In this case, with this newborn, you can see this tube here. This is the shunt. They are draining that fluid down into the abdominal cavity, where then it can be reabsorbed at that point. Excuse me. The blood-brain barrier, this helps maintain this very stable environment for the brain. You do not want any chemical, any nutrients, or a lot of toxins that you take in your body. You don't want those to come in contact with the brain, because it can damage the brain. It could cause the brain to start misfiring. So there is what we call the blood-brain barrier. This is a protection mechanism. Any substance that's going to gain entry into the neurons of the brain have to pass essentially through 3 different layers. They're going to have to go through the layers of the capillary walls. There's actually additional layers there, and then the astrocytes before they can go into the neuron. The barrier is not absolute, it's selective. So it allows some nutrients to move through, but not everything. So it allows a lot of the nutrients, however, it will not allow certain proteins, toxins, most drugs are not allowed. Potassium is not allowed to pass through. A lot of fat-soluble substances can pass, including alcohol, nicotine, and anesthetics. With traumatic brain injuries, there's different types of injuries. A concussion is when there's a temporary alteration in the function. A contusion is when there's permanent damage. Subdural or subarachnoid hemorrhage, there's pressure from the blood that forces some bleeding, and that can result in death if not caught early enough. Cerebral edema, swelling on the brain, which is associated with injury. Cerebral vascular accidents, or CVAs, often referred to as strokes, where you have had an interruption in the blood supply to an area of the brain. It can lead to damage, death to the tissue of that area. There may be a blockage in an artery. There may be a blood clot that is there that is causing an area of the tissue to be deprived of oxygen, and that's what's going to cause the damage. You may have, depending on the area of the brain where the stroke has occurred, you may have paralysis then on one side, because it's all dependent on where the stroke has occurred. There may be sensory defects, there may be speech issues, TIAs, transient ischemic attacks, temporary episodes, usually it's reversible. Tissue or TPAs is the only, this tissue plasmogenic activator is only a treatment for stroke you need to start as soon as possible. If you think someone is having a stroke, don't sit around for 4 hours. Well, I don't know. Should we take them in? Should we not take them in? One thing that they often say, if you're wondering if someone's having a stroke, just give a simple phrase and see if they can repeat it. The little red wagon is here. Can they repeat it clearly? If they're having problems, if they're slurring, that may be a clue, and they didn't used to slur, that might be a clue they're having a stroke. Ask them to raise both of their arms straight up in the air. If they can put one arm up but not the other, that's an indication, and it gives you a clue once again as to what side of the brain is being affected. Let's say they cannot lift their right arm up. They can't move it. That gives you, if it's the right arm, that tells you, ooh, problems on the left side of the brain. All of this is important information. Get them to emergency room as soon as possible. Just an interesting side note, because you need to start treatment as soon as possible. Several years ago, when my daughter was working in a lab in one of the Albuquerque hospitals, they, while she was there, right before she left, implemented a new thing that any of you have worked in hospital settings, you know that in the lab, a lot of stuff is color coded, like the tubes for getting different blood tests. That's all color coded. So, excuse me, they started a new procedure of, if anything came in, if they had a stroke, potential stroke patient, any sample that they took, that went directly in a white bag. And so the lab knew that if anything came in a white bag, you stop everything else. That was stat. You do that right now, because not only stat, that's meant stroke victim, potential stroke victim. It needed to be analyzed right away so they could start treatment right away. And it's like, well, why didn't we start this a long time ago? That makes a whole lot of sense. When you're busy working in the lab, to have things color-coded is a wonderful thing. As you know, there are several different types of degenerative brain disorders, things like Alzheimer's, which is a progressive degenerative disease. You end up with dementia, memory loss, short attention spans, confusion. We don't know exactly what causes it yet. There's a lot of research going into this. What we do know is that the brain cell dies and the brain starts to shrink. You can monitor this over time. This is a normal brain. This is an Alzheimer's affected brain. Um, this is, you can just see without the stain dyes on it, measuring brain activity, just the brain itself. Sometimes my mother, although she actually passed away from cancer, she did have Alzheimer's at the end. And when they did brain scans, it was very obvious, the decrease in the brain mass there. Obviously, a lot of research going in for all of these different types of brain disorders, trying to find up treatments, cures, etc. Parkinson's is another one. In this case, the cause, there are some theories, but the cause is unknown. There are some drugs that help to treat some of the symptoms, and like I said, there's a lot of research going on in all of these different areas. Huntington's is a hereditary disorder. It is fatal. You tend to have very kind of floppy, uncontrolled movements. It has been treated with drugs. It's usually fatal within 15 years of onset, though. Not a good outlook. There's different procedures that you can use for assessing different types of central nervous system dysfunction, oftentimes looking for reflexes. All of you are probably familiar with the knee-jerk reflex, where you use a little hammer and you tap it. You're looking for the movement. If there is no movement, that can indicate some type of abnormalities you want to look at. Obviously, you can do MRIs, you can do PET scans, CT scans to look for whether it's lesions or tumors. It depends on what's going on with your patient. You don't automatically say, oh, let's do an MRI. It depends on what's going on with that particular patient. What information are you trying to obtain? How will that help with your diagnosis? Therefore, how does that help with your treatment? So obviously, you have to look at each situation separately. You can use x-rays with dyes to try to pinpoint where there has been a stroke, where there are clots. With a cerebral angiogram, you can do ultrasounds. So it just depends on what you're trying to look at that particular moment in time. So that is the brain. Now we're going to move on to the spinal cord because we're still within the central nervous system. So the spinal cord, it's protected by the vertebral column. It's in that foramen. It starts at the foramen magnum and then moves down through the vertebral column. It ends about L1 or L2. It is providing communication in two directions. So it's a two-way street, if you will. It's providing information up to the brain from those sensory nerves, and then it is providing information down to the motor nerves coming down from the brain. It is a major reflex center, meaning that some reflexes actually never make it to the brain. They're initiated and they are completed at the spinal cord. In terms of protection, it's protected by the bones of the vertebral column, it's protected by the meninges, and it's protected by the CSF. Now remember, the Dura Mater for the spinal cord is only one layer thick. The epidural space, this is the area, the space between the vertebrae and the Dura Mater. It tends to have a lot of network of veins. It has a lot of fat for cushioning in there. So when you receive an epidural, it's going in that epidural space. The Cerebrospinal Fluid is filling the subarachnoid space between the arachnoid and the pia mater. Like I say, I mentioned earlier, if you do a spinal tap, it's a lumbar puncture, you're going to go just below the L1 or L2. Usually you do it about the L3 for the spinal tap, so that you do not hit the spinal cord at all. Excuse me. So this is showing the spinal cord here going down, and it actually ends right about in here. So you're going to do a spinal tap right below it. You do have nerves extending off from the spinal cord, still moving down but the actual spinal cord itself ends right here at the conus medullaris is the end of the spinal cord. Excuse me. So this is showing how, that's why it's important that they'll feel for the spinous process back here on the vertebrae to get the location. And then now for the lumbar, now if you get an epidural, they're going to put it in the epidural space. If you're getting a spinal tap, they're going to come in here to the subarachnoid space to retrieve that fluid. So this is a spinal nerves coming down, but it's not the spinal cord, which we'll explain in a second. So that spinal cord, it terminates at that conus medullaris we saw in that previous picture. You have fibrous extensions from the spinal cord that help to anchor it in place, called the filum termini. You have various ligaments that are extensions of the Dura Mater that secure that cord to the Dura Mater. You don't want any of the meninges slipping and sliding over the spinal cord. You have to hold it in place. So that's what the denticular ligaments are doing. Is they're helping to secure, basically they're extensions of the pia mater. They're securing the spinal cord to the Dura Mater so it's not sliding all over. There are two enlargement areas, the cervical enlargement and the lumbar enlargement areas. This is where you've got nerves coming out that are going to the cervical area, service the upper limbs, neck area, and then from the lumbar enlargements, they service the lower limbs. The spinal nerves, now they come out from the spinal cord because they're attached to the spinal cord, but they are not part of the spinal cord. They are actually part of the peripheral nervous system. There's 31 pairs of these, but they attach to, excuse me, to the spinal cord. Just like you have 12 pairs of cranial nerves that are attached to the brain, but they're not part of the brain. And then the cauda equina, that's a collection of nerve roots at the very end of the vertebral column. So if we look at a cross-section of the spinal cord, you're going to notice that there's two, they refer to them as grooves. There's two indentations, and it basically divides the spinal cord into a right and a left half. Obviously not all the way through, but almost. On the anterior side, there's the ventral median fissure, sometimes called the anterior median fissure, and then you've got the dorsal or posterior median sulcus. One thing, remember with the spinal cord, when we look at gray matter versus white matter, the gray matter is located in, excuse me, interior, and the white matter is located more superficially. In the middle, there is the central canal, and that is filled with cerebral spinal fluid. So you've got cerebral spinal fluid on the outside of the spinal cord as well as running through the middle in that central canal. So if you look at a cross-section of the spinal cord and the vertebrae, which is kind of neat because it shows you the spinal cord relative to the vertebrae. If you are looking at it, so here's the body of the vertebrae, the main part of it. So this is the front, here's the back, there's the spinous process of the vertebrae that you can feel if you run your hand down the back. That's what you're feeling is this. In the foramen, in that space in the middle, that is where your spinal cord is. So here's the spinal cord, very middle, that little black dot, that's the central canal. You have your spinal nerves, which are in yellow here, that are attached to the spinal cord, but like I just said, they're attached to it, but they are not part of it. They're part of the peripheral. They will come out between the vertebrae, so there's going to be another vertebrae on top of here. So they rest in the space here, and they come out and they innervate the rest of the body, whether they go down to your leg or your arm, wherever. You can see in this outer space here, this lighter yellow here is fat. That's in the epidural space. And then we'll look at an enlarged version of this so you can see the subdural space versus the subarachnoid space. the three different layers, pia mater, arachnoid mater, and dura mater of your spinal meninges. And from a side view of it now, obviously without the vertebrae in here. But you can see the dura mater is the outermost layer. The middle layer is your arachnoid layer, and then right up attached directly to the spinal cord itself is the pia mater, just like it was with being attached directly to the brain. You do have blood supply going between the arachnoid mater and the pia mater in that subarachnoid space. That is also where the cerebrospinal fluid is, which is why you don't want to do a spinal tap to collect that fluid where you actually have the spinal cord here, because you don't want to hit the spinal cord. You'll notice right in here, it's the central canal. Is that space where the cerebral spinal fluid is. We're going to talk about all of these different areas, but as long as we have the picture here, just point out with the spinal nerve, as it approaches the spinal cord, you do have the separation here, and on the front side you have the ventral root. That, I'll tell you right now, contains motor neurons, so it's going to be taking the message from the spinal cord and moving away from it. On the back side is the dorsal root that has sensory information. So it's mixed here and then it separates. The sensory goes back here, bringing the information to the spinal cord, and then on the front you have the dorsal root, which contains the motor information. And then, like I said, they come together here mixed because it has both sensory and motor. Now this swelling on the back side, which here's a clue if you ever just given a cross section and you forget, like, oh, what's my orientation? Look for this, the dorsal root ganglion. It's a swelling. This is always going to be on the posterior side. That's where you have a whole group. Dorsal root ganglion is a group of cell bodies in the peripheral nervous system. So that's where you have a whole bunch of cell bodies. In terms of the gray matter, remember it's more interior on the spinal cord. The white matter is on the surface more superficially. The white matter, we call them columns or funiculus. And you're going to be given the name, the location, dorsal funiculus, lateral funiculus, ventral funiculus, and then, or column. You can see it either way. And then the gray matter are referred to as horns. You notice it kind of looks like a butterfly here. And so they're also going to be given the names of the dorsal, the lateral versus the ventral horn on either side. Where the gray matter passes from one side to the other, from the left to the right or vice versa, that connection is known as your gray commissure area. The white commissure area is where the white matter passes or transfers from one side to the other. This indentation right here on the front is a ventral median fissure, and then on the back you have the dorsal median sulcus on there. So that gray matter, like I said, kind of resembles the nature, looks like a butterfly. And as we just saw, you've got the dorsal horns, the ventral horns, and the lateral horns. We've been able to separate out that we know that the dorsal horns, this is interneurons receiving somatic and visceral sensory input. The ventral horn, there's some interneurons there, but it's mostly somatic motor. And the lateral, that has some of your sympathetic neurons. So you start to see that basically the ventral is more motor, and the dorsal or posterior side is sensory. That gray commissure area, once again, like that's where it connects from one side to the other. It surrounds that central canal. The ventral root has the motor neurons that are leaving the spinal cord. The dorsal root's bringing sensory information to the spinal cord, and that dorsal root ganglion has the cell bodies. And then you've got your spinal nerve where it fuses together. The gray matter can be grouped into either somatic versus visceral. Somatic, think skeletal muscles, voluntary control. Visceral, think more abdominal. autonomic. You don't have control over it. And for both of those, you're going to have sensory, so you have somatic sensory, visceral sensory, and then you have visceral motor and somatic motor. And so it's just showing you the breakdown. And I think in this drawing, it might be easier for you to see. Sensory is coming in on the dorsal root, passing through the gray matter, and then information is leaving the spinal cord via the ventral root, the motor here. And so sensory is coming in the back. Just, it might be easier just to kind of visualize, kind of drawing a line almost halfway through to a front and a back. And the back section, the dorsal section, is sensory, and that's going to allow you to remember on the gray material as well as the nerves. And then the front half is motor. The white matter, remember, once again, as always, it's going to be mostly myelinated nerve fibers. So there will be some non-myelinated in there as well. These fibers are allowing that communication between different parts of the spinal cord and allowing the information going from the spinal cord, bringing it up to the brain. So you've got three different directions running. You've got ascending, which is bringing it upwards. That's going to be sensory information. Descending is bringing from the brain, or higher up on the spinal cord, bringing it back down. So it's descending is moving it down. That's going to be motor. Transverse is where you're going from one side to the other, and those are known as commissure. So as we saw earlier, the white matter is divided into three columns or funiculi, once again given the location names dorsal, lateral, and ventral. As we saw over here. So here's your white matter. Here's your dorsal, here's your lateral, here's your ventral columns. Ascending tracks. Once again, think of this line here. Most of it's going to be in the dorsal side, going up for ascending. Descending is more along here, more towards the front. In terms of spinal cord traumas, localized injury to the spinal cord or its root going there is going to lead to some loss. If you have damage to the dorsal root, that is going to lead to sensory function loss, because that's bringing the sensory information in. You won't feel anything. Let's say you have damage to a sensory root that's innervating your arm. Are you going to be able to move your arm? Theoretically, yeah, you can move it, but you're not going to feel any pain. Paralysis is caused because of damage to the ventral root. Why? Because that's carrying the motor information. So you can feel the pain, but you can't do anything about it. Flaccid paralysis is where there's been severe damage to the ventral root or the ventral horn cells. So the impulse never gets to the muscle. There's no control of the muscle. The muscle's going to atrophy. Spastic paralysis is when there's been damage to the upper motor neurons or in the primary motor cortex area. So the spinal neurons are intact. Muscles can be stimulated by reflexes, but you don't have any voluntary control over that. If there is any damage cross-section, like a break, a cut of the spinal cord is what they're talking about, transection, where the spinal cord itself is cut, you are going to lose both motor and sensory function of anything below that damaged area. Paraplegic is where the transection is between the T1 and the L1. So you're not going to be able to move your legs. Quadriplegic is where it's in the cervical region. So now you're not going to have use of your legs or your arms. Spinal shock is where you have just a transient period of loss. It's usually due to some type of a lesion. Polio Mellitus. this polio is a disease caused by a virus. There's destruction to the ventral horn motor neurons. The muscles start to atrophy. Now, there are different levels. Some people do not have paralysis where maybe it just affected an arm or just a leg. In severe cases, what would happen is death would occur because of paralysis of the muscles that are necessary for you to carry out respiration, to breathe. Now, years ago, and most of you do not remember this, most of you are way too young, of learning about the iron lungs, where they used to have to put people who had severe cases of polio because they could not breathe on their own. You have to use a lot of your thoracic muscles and your diaphragm to help you breathe. And if those muscles were affected, you can't breathe on your own. And so they would put them literally in these, they look like big tubes with just their head sticking out. That was referred to as an iron lung. And basically, it did the breathing for you because you could not breathe on your own. I actually had a professor that worked at Walter Reed Hospital back in the 50s, and that's not when I knew him. That was before my time. But he was there in the 50s and 60s, and he used to work on a ward. He talked about where they had patients who were unfortunately, in iron lungs. And he shared with us one time he said it was the worst day of his life. They had a power failure, and before their generators could kick on, and these iron lungs are run electrically. So when they lost power, they stopped working. And he had, I think he said, about 20 patients that were in these iron lungs. They can't breathe on their own. And for some reason, there was a delay with the generator starting up. And he was by himself. And there was a hand crank that you could turn to run the iron lungs. And he said it was horrible because he would start at one end of the room, crank one for a little bit, run to the next one, crank it a little bit, run to the next one, crank it for a little bit, and was just praying he could get to the 20th person, crank it enough, and that the first person was still holding on enough, and he was just running and doing this. And he can see their faces, and they're looking at him, they can't breathe, and they know he's trying to do the best he can, but he was just one person. He said it was just a horrible experience. Survivors often will develop post-polio syndrome many years later because of the neuron loss. There are two different types of polio vaccines that were developed at the same time. One is the Savin and one is the Salk vaccine. One thing I just want to say is that some people mistakenly think that polio has been eradicated because the vaccine process has been so effective in reducing the number of cases of polio. It's been astounding how well this vaccination program has worked. The problem that we're starting to see now is that some individuals feel as though, oh, well, polio, it doesn't exist anymore. That's a disease from a long time ago. Well, it's not existing because of the successful vaccination program. And you have a whole group of people who are growing up who've never seen polio. They've never seen the effects of it because since they've been alive, we've had the vaccines. I mean, I remember growing up, I had a great aunt that had polio. She had a limp because of it. A friend of mine, her dad had polio. His hand was crippled from it. So I grew up seeing older generations who had polio. Now, I was in elementary school and they came out with the vaccines. And so I remember getting the vaccines. And like one of them, they put it in a sugar cube. We thought it was great because we got to go to the library and everybody was given a cup and you ate the sugar cube. And as far as we knew, it was like candy. It was great. We didn't know we were taking medicine and it wasn't a shot. So we thought that was wonderful. I will say the teachers did it at the end of the day, so it's kind of like, yeah, you're going to give the kids a sugar cube. Please do it at the end of the day so then we can send them home. Polio, some areas of the world, it's one of the ones that we're hoping to get eradicated. But unfortunately, it's not. And in some areas, it is increasing. And we have successful vaccines. There's no reason why anyone, especially a child, should have to suffer from polio. It's a devastating disease. Another spinal cord type of trauma disorder in this group is ALS, also known as Lou Gehrig's disease. Some of the symptoms: loss of ability to speak, swallow, and ultimately breathe. The ventral horn motor neurons are being destroyed. Usually death will occur within 5 years of diagnosis. What causes this? Seems that some environmental factors may play a role. There may be some genetic mutations that are occurring. And unfortunately, there is no cure at this time for it. There's some treatment that can help, but it's not a cure. And then cerebral palsy. This is a neuromuscular disability. You have very poor control, or actually it can reach sometimes paralyzing your voluntary muscles. What causes this? Usually there's brain damage. Oftentimes it is associated with a lack of oxygen during birth, during childbirth. Results with speech difficulties, motor impairments. Some patients may have seizures. Some may be deaf. Visual impairment is fairly common with this. There are times when the cerebrum or parts of the brainstem may never develop, and usually in this case, because the brain's not developing properly, it can't function properly. Remember, structure determines function. So if the structure is abnormal, then the function is going to be abnormal. In most cases where parts of the brain do not develop, if the infant is alive at birth, usually death will occur shortly after birth. Spinal bifida is an incomplete formation of the vertebral arches. There's different levels of this as to how severe that's going to be. They can go in and do surgery in some cases. Spinal bifida cases are certainly decreasing now that we know that most cases are caused by a lack of vitamin B, the folic acid. So if a woman is pregnant, it is mandatory. If she's seeking doctor's care, it is mandatory that they prescribe folic acid. Well, you can get it over the counter, but they have to advise the woman to take folic acid supplements. That's in your prenatal supplements. Since that has been instigated, the number of cases of spinal bifida in the U.S. has dropped significantly.